Hey everyone, this is going to be a small lecture on the final exam content. And we're just basically going to start at the beginning and just work our way through it. Some of these things you may not have looked at in a while, so we just want to give you a little bit of a refresher. First of all, you're going to see medications listed on the exam. It's not going to be a question that is only going to be about the medication. It's going to give you a little bit of a scenario behind it too. So it's really important to know different routes of the medications, creams, ointments. I'm not going to really talk about those as much, but it is good to know as far as content for 432. But I'm absolutely going to be having questions on the exam about oral medications, sublingual medications, and so on. So just be aware, including injections, because diabetes is on the exam. So of course there's going to be some sub-Q questions. You're going to need to know what the 6 rights are. And then high-risk substances. So that's going to be like your potassium, your morphine, your PCA pumps, and so on. And then know what to do if a medication error occurs. There's going to be at least one question about calculating IV flow rates. So make sure that you review the calculation that's listed here. So you want to know what your total amount is that you're giving. If it is a drip factor question, of course, you'll need to know the drip rate, the drip factor rate, and then that's going to be divided by time in minutes. Or if in the case of a pump, like a lot of times we are using the pump, my face is in the way here. I'm going to turn that off. Well, that didn't work. Okay, that's better. So what are going to be some of your complications of IV therapy, and what would you consider before administering fluids, and when would you remove an IV? To talk about solutions, there's going to be 3 that I really want you to know moving forward for 432 and for your other classes. And that's going to be your hypertonic solutions, your hypotonic solutions, and your isotonic. So with your hypertonic solutions, if you're going to be placing an IV in your patient and running those solutions, just be aware that water is going to leave the cell. Then the cell is going to shrink. So with hypertonic solutions, it's going to be pulling that water out of the cell. With hypotonic, the water is going to enter the cell. So the cells are going to swell. And the way that I remember the differences between those is the O and the hypotonic, to me, just kind of looks like a cell, like a really full cell. I know that seems like a pretty simple way to remember it, but it seems to work for me. And then isotonic, there's absolutely no shift between the two. So no hypertonic, the cells are going to shrink, and then with the hypotonic, they're going to expand like that O that's in the middle. And yes, electrolytes are not going anywhere. I'm not going to read off every single value to you. The ones that are going to be the most important for the exam are pretty much these that are going to be listed here. So the sodium 135 to 145, potassium 3.5 to 5, your calcium levels, your mag levels, your phosphorus, and so on. Be aware that with BUN, we're going to be looking at dehydration with that particular lab, and then of course your creatinine for muscle waste and kidney function. The other important thing when it comes to labs, we don't want to just know what the normals are, because the test question's not going to say a sodium level is 130. Is that hyponatremia or hypernatremia? They're going to give you a little bit of a story and then kind of ask you a question based off the manifestations. So I really want you to know what happens when the lab is abnormal and what you do from there. So when you're looking at dehydration with your clients, make sure that you're concerned with the very old populations, the elderly populations, as well as the pediatric ones. So my concern when caring for an elderly client that is confused, a lot of times they don't have a thirst mechanism, a thirst drive, and they might forget to take a drink. So you want to really be encouraging them to drink, delegate to your CNA, oral intake as well, and manage their hydration status. Along with this goes with the assessment findings. So you're going to be checking their skin turgor, you're going to be looking at their mucous membranes, you're going to be looking at their labs, and so on. So you really want to take the whole picture into consideration with that. And along the same lines with your dehydration, I also want you to know the signs of fluid volume overload. So you're going to be checking for your bounding pulses, for edema, for crackles in the lungs, and those kind of things. So you need to really know both manifestations, the manifestations of fluid volume deficit as well as fluid volume overload. With hyponatremia, I want you to focus on the signs and symptoms of this. So make sure that you're aware that hyponatremia can cause altered level of consciousness. They can have muscle twitching, lethargy, weakness, limp muscles, orthostatic hypotension, and of course seizures, headaches, and stomach cramping. On the flip side, we have the hypernatremia over here. So they could have a fever, flushed skin, restlessness, increased fluid retention. So they're going to have some edema and decreased urinary output and dry mouth. Potassium, that's going to be one of the bigger ones that you're going to see in a lot of NCLEX questions. So the normal range on this is 3.5 to 5. Anything more or less than this can be life-threatening, so you really want to think about how it affects the heart. Get those patients on telemetry if they're having any type of hyper or hypokalemia. With the diuretics specifically, if your patient is on a lot of Lasix, we talk about Lasix a lot, you could have some issues with some hypokalemia there. So make sure that that is being monitored. You could have issues of hyperkalemia with renal problems. You also need to watch your diabetics with their calcium, but just get these guys on telemetry if they're having any type of imbalance. Hypo and hypercalcemia. So with these, I want you to take a look at the manifestations. What type of signs and symptoms are you going to see with these patients? With the hypocalcemia, they could have convulsions, arrhythmias, and tetany. So really kind of focus in on that tetany there. With the hypercalcemia, they could have issues with their bones. They could have abnormal bone remodeling. They can have increased fracture risk. They could have kidney stones. So I really want you to focus on these two as far as that's concerned. But just don't forget about the tetany with the hypocalcemia. Speaking of tetany, there is a couple different videos you can watch on Chvostek sign and Trousseau sign. So this is where you're going to be tapping on that nerve on the face, and it just kind of, I'm not going to be able to mimic it, of course, exactly, but it just kind of jerks up like that, and it'll stay in rigidity the whole time. So it just kind of freezes that way. This one with the Trousseau sign, that is when you're putting a blood pressure cuff on them. You're inflating it to cut off the circulation, and the hand kind of, I don't know if you can see my hand, but it kind of does that. And you are more than welcome to look up videos on those particular ones. So you got to think about that as far as hypocalcemia is concerned. The other thing with your electrolytes is know the relationships between these. So when you have, for example, I think of it kind of like a teeter-totter with sodium and potassium. So when one of them goes up, the other one goes down. So you're going to really see an inverse relationship with that. Same thing with your calcium and your phosphorus. So just make sure that you're knowing the relationships between the two. This is especially important when it comes to being on the floor and electrolyte replacement therapies. You'll have patients that are just eating potassium like crazy, and you keep infusing them, and it doesn't seem to make a difference. And then come to find out the whole time they've had a magnesium problem, so their magnesium ends up being low. So once you correct the magnesium deficiency, a lot of times the potassium becomes stabilized. Then we're going to talk about operative here. First of all, probably going to mention incentive spirometers more than once. So here we have an incentive spirometer. A lot of times when you have a patient that's going for surgery, we don't often admit people the day before, but with joint surgeries, they'll go to a joint class a couple weeks prior to having surgery, and they might give them the incentive spirometer, they might give them a cryocuff, something that they're going to teach them on before they actually go through the surgical process. So we're really going to be using this to prevent atelectasis. We also want to focus on the SCDs as well. I like to educate people before the fact. That way it's a little bit less scary for them. So if you can imagine what it's like to go into a medical setting and you have no background at all, you want to tell them that they're going to have all this equipment on them. So you really want to tell them why they're wearing the SCDs. We're using that to promote venous return, so that way they don't have venous stasis, and it ultimately is going to help prevent DVTs. And then, of course, the pain scale is going to be pretty important with this too. So we want to educate the patients on pain and pain medication. We want to tell them in advance that they're going to expect some pain with surgery. Some people, for whatever reason, they just don't realize that with surgery also comes pain, and that it's really okay to use treatment to help alleviate those symptoms. So we can give the patients ice, we can give them pain medications, narcotic and non-narcotics, to help with their pain. We can distract them, we can use family. There's a whole lot of things that we can do to help with their pain. We want to educate them on it though. And then there's different types of surgery. So I want you to really know the different types of surgery. I gave some examples on some elective ones here. Like with these particular surgeries, you have to remember that even though a hernia is unfortunately painful, and cataracts, of course, are going to cause visual deficits, those are optional surgeries. You don't have to have your tonsils out. You don't have to have your hip out. So make sure that you really know the differences between the elective surgeries, different types of surgical procedures. Let me look at my notes here. So palliative is going to be another example. Of course, cosmetic, we talked about those, transplants, and then minor versus major. I don't know if you can hear that, but they're having a party in the hallway. Informed consent, a little bit about informed consent. I know we've talked about this a few times. So really, when you're talking to your patient about a procedure, the physician's going to come in and educate them. They're going to explain to them whether or not the surgery is necessary, what other options they have, and the risk and benefits associated with each one of those. They should be telling them side effects like expect pain, expect you're going to need physical therapy, whatever it is. So they really need to understand that before they sign it. It is completely voluntary. You want to provide the provision of information like I just discussed, comprehension of the information. You want to make sure that they understand it and that they're competent to make those decisions. So when you are signing that consent, the nurse's signature is really saying that the patient is competent and able to make the decisions for that they understand everything. Integumentary. So first of all, don't forget about your Braden scale. This is the scale we use to score our patients to determine if they're high risk or not. In my professional opinion, any patient that is in the hospital is at a high risk for falls and a high risk for skin breakdown because they're not at home. We've taken them out of their environment. They're not well either. So unless they are like 18 and completely ambulatory and they're only in there for something outpatient, in my opinion, they're going to be high risk. So we need to provide interventions for that. So our interventions are going to be targeted at pressure ulcer prevention. So we really want to look at those bony prominences. We're going to do a thorough skin inspection. They call it a four-eyed skin check when you have two sets of staff. Either some floors require both to be nurses, some will allow a nurse and a CNA, but you want to inspect the skin for any skin breakdown. And really, the prevention is what we're looking at. So turn your patients. I cannot stress that to you enough. I sometimes will challenge students when they're studying specifically, because it's like a perfect time to do this, to, you know how when you're sitting there, after a while, your butt starts to hurt. You just get sore from sitting too long. If you can try to focus and not turn yourself, can you imagine how much agony you're going to be in? Well, sometimes your patients are feeling that, and other times, unfortunately, they have neuropathy and they can't feel it. So eventually their skin's going to break down. So you want to make sure that you're turning them. Offload, use lots of pillows, tons of pillows. You want to offload all their bony prominences and then take them to the bathroom. Nothing is going to cause a coccyx injury faster than sitting in one spot and being incontinent. So I do this with my patients, and it actually saves time, because I hear people say, well, how do you have time to do this? To me, it's easier to take them to the bathroom on a schedule, like every 2 hours or however that person needs it, rather than cleaning up incontinence. It's really going to save you a lot of time in the long run. Cellulitis, I'm just going to touch on this a little bit. So with cellulitis, we've got an inflammation. It's a skin infection. It can go into just the really shallow area of the dermis. It can go deep down. It can actually get into the subcu fat level as well. So with these, we're measuring it. You can see here that it's being measured here. And really that is to determine if it's getting any bigger or smaller. And I know I've talked about this before, but itis, anything itis is an infection. So what we're going to be doing with these patients is we're going to be treating infections. We're going to be monitoring CBC. If there's any open areas on here, we would want to do a culture, and then we're going to be giving them some antibiotics targeted towards that cellulitis. Oh boy, shingles. I always feel bad for anybody that has herpes zoster. It is like one of the most painful things. So here we have herpes zoster. It is going to be following the nerve path. So you'll see like a unilateral type of rash, and it kind of looks similar to what you would see with a patient that has a cold sore. These patients are going to be placed on isolation, so you're going to have contact isolation. There's going to be a sign on the door. You want to keep pregnant women out of here because it crosses that placental barrier and it can cause harm to the baby. So anybody that is on a floor where these patients are, you would, if you're the charge nurse, not want to assign that patient to a pregnant nurse. The other thing is that they should be started on a cyclovir, and that is an antiviral that's going to help with the shingles. There's also a vaccine for shingles now that has become more popular. And then the other thing with them is they have quite a bit of pain. So they'll have nerve pain, and really if you give them a narcotic, it doesn't always help. So sometimes they need something a little bit stronger that's targeted towards that, like gabapentin. To talk about pressure injuries again, What I want you to focus on here is your assessment. So when you're taking a look at this, I want you to know the differences between a stage 1, stage 2, stage 3, and stage 4. So you literally can read off this description. So stage 1, we have a non-blanchable erythema of intact skin. So that means when you're taking your thumb or whatever you're doing to assess your patient and you're pushing on that area, it does not blanch, so it does not turn pale. So it's going to stay the same color. Partial thickness loss, that's going to be your stage 2. That's going to be involving the dermis and or the epidermis, and it's going to be superficial. So sometimes this can be misinterpreted as shearing, but you're going to have a loss of skin there. Stage 3 is going to be your full thickness skin loss. That's going to have damage or necrosis. It can go into the subcutaneous tissue, so it's going to be deeper down. It's going to extend down. And of course, the stage 4 is going to be going all the way down to the muscle and the bone. ABCDE rule. So you want to know this rule for detection. A is going to be your asymmetry. So one side is going to look different than the other. They're not going to be symmetrical. The borders are going to be irregular. You're going to have color variations or multiple colors in there. The diameter, that's going to be bigger than 6 millimeters, and then it's going to be evolving. So you always tell people that if this changes over time, you need to have it checked. Diabetes, you want to go over the different types of insulin, what their onset and peak times are. And then there's some questions over here on this side. So with this, I really want you to take a look at what you're going to be educating your patient on. How are they going to be giving their insulin? Can they mix their insulin? Which insulins can be mixed and which ones can't be mixed? So you know that you cannot mix Lantus. So make sure that your patients are aware of that. Where to give the insulin on their body, how to prevent lipodystrophy. So you want to rotate those sites because you don't want a breakdown. And then what do you do if you accidentally take too much insulin or give your patient too much insulin? How are you going to prevent any hypoglycemia? And then the 15-15 rule, which we're going to talk about a little bit more in depth here. With diabetes, so we want to prevent long-term complications by controlling their blood sugar. We really want to control the extremes, the highs and the lows. So we want to control hypo versus hyperglycemia. And of course, here's a list of some long-term complications that a diabetic client might have. They can end up with cardiovascular disease, diabetic retinopathy, diabetic nephropathy. So they can actually end up in renal failure because of it. They can have periodontal disease, peripheral vascular disease, and a whole host of other issues as well as a result of poor blood sugar control. Sick day management. We want to tell these patients that they still need to take their blood sugars and check them when they are sick. Sometimes they assume that because they've had a lot of vomiting that they might not want to check their blood sugar because they're just going to assume it's going to be okay. No, that's not always the case. Usually when diabetic patients are ill, their blood sugars get all wacky and out of control. So we want to tell them to be checking their blood sugar more often. If it's applicable to that particular client, test their urine for ketones. They would want to continue their basal insulin. So their basal insulin is going to be like if they're on an insulin pump, that would have a basal insulin to it. And Lantus would be another example of a basal dose of insulin. If they're not eating, they may need an antiemetic to help keep down some fluids because we don't want them to get dehydrated. And they're still going to take the rapid acting or short acting insulin when they check their blood sugar. So they could still have blood sugars in the 300s even when they're not eating. And then they need to know when to contact their doctor and when to go to the emergency room. So with hyperglycemia, these patients are going to have polydipsia, polyuria, they could have a headache. We want to really monitor those highs. So they could be going to the bathroom all the time. They could be really thirsty, dry mouth, blurred vision. There's a whole lot of factors that are associated with hyperglycemia. Then on the flip side, we've got our hypoglycemia. I know I've talked about this before. My husband is diabetic. He's had some times where he's gone down into as low as the 30s before he actually starts to get symptomatic, except for headache. Headache is usually the one thing that happens to him before anything else, but they can get diaphoretic, weak, hungry, shaky, so they kind of look like they're nervous. And when I say diaphoretic, I mean it looks like he just got done running a marathon. And I always know that his blood sugar is low if that is happening. So make sure that you check their blood sugar and then of course treat it. So you can treat it with 15 grams of carbohydrate. I like to use a fast acting carb like orange juice. So you give them 4 ounces of orange juice, or you could even get them the oral solution. So they have them like a little pack. They're coming like little tiny juice boxes here at the hospital, but the ones they give to patients at home, it's like a little pouch. They just rip open and drink that. And then 15 minutes. So it's 15-15 rule. To treat low blood sugar, you give them 15 grams of carbs, and then you check their blood sugar again in 15 minutes. If it is really low, like below 50, I would give them 30 grams of carbs, but that's just me. Just looking to see if I want to say anything else about that. So we really want to prevent complications. Diabetic education is going to be key. Sick day education, prevention of complications, foot care. These patients are going to have peripheral neuropathy, so they can't feel it. They could have a rock in their shoe and not know it's there. They can get, like from flip-flops, we tell them not to wear flip-flops. They can get wounds between those toes and they can't feel it. So, and then of course, how to give themselves insulin and how to administer it. One last thing about diabetes, especially with medications, you need to think about if you have a patient that's going for a test. Now, you can't help it if it's an emergent CAT scan. You don't know what kind of medications they've taken that day, maybe. But if you have the ability to know, have the foresight that, hey, my patient's going down for a CAT scan in 2 days, or you're calling to give education on a CAT scan, make sure that you find out if they're diabetic, so you can talk to them about their metformin. But I would still ask them, are you taking metformin? Because sometimes the physician will put them on metformin for weight loss to help control blood sugar, like in the pre-diabetic or in other disorders too. So just make sure that you find out if they're on metformin, because that medication needs to be held before and after a CAT scan. So with endocrine, you want to know what the thyroid gland does, what types of diagnostics that you're going to be checking. So you're going to be looking at your T3, your T4, and your TSH levels, and really need to know what those labs are telling you. With hyperthyroidism, there are a ton of manifestations with these, and I have another slide that kind of goes into a little bit more on it, but just know that these patients are revved up. Everything is too fast, too much. So tachycardia, hypertension, arrhythmias, increased body temperature, the expelomosis, that's where their eyes are kind of bulging out, the goiter, so their thyroid gland is going to be enlarged, they're going to be nervous, they could have diarrhea, weight loss is going to be a huge one with that. These patients are pretty thin. So we've got revved up, so they can have excessive secretions of T3 and T4, and this is going to be affecting the metabolic process in the body. So everything is increased, their metabolism is up. They can eat a lot of food and not gain any weight. I used to think, oh gosh, I wish I had hyperthyroidism and not hypothyroidism. But hypothyroidism, which we're going to talk about in a minute, is a lot easier to manage than hyper. And hyper has a lot more manifestations. So everything is revved up. They're hyper. So treatment for this is going to be anti-thyroid medications. They're going to have their Tapazole. Sometimes they even resort to a thyroid ablation where they'll give them radioactive thyroid or radioactive iodine, and it ablates the thyroid. Really, with this one, we're going to do anti-thyroid medications and, of course, a thyroidectomy. So with the thyroidectomy, we're talking about removing the ectomy part is taking it out. So we're taking out the thyroid. You want to, with these patients, monitor their airway because this is a very small area. You don't want them to get swelling. So if they get edema there, you can get compartment syndrome anywhere, but if you had swelling here, it's not going to progress to compartment syndrome before it cuts off their airway. So you don't want to lose their airway. You also want to assess for laryngeal nerve damage. So with these patients, their voice is going to be a whisper if they're having laryngeal damage to the laryngeal nerve. So hoarseness of voice, laryngeal damage, and again, it's going to be like a whispery voice. The other thing, hyperthyroidism, you're taking that thyroid out. You could have issues with hypocalcemia with this. So that's where you're doing that Chvostek sign again. So make sure that you are monitoring that. Hypothyroidism is going to have everything, it's the opposite of hyper, so everything's down. So you're going to have decreased T3 and T4. You're going to have an increase of TSH if the cause is actually the thyroid, and a decrease in TSH if the cause is the pituitary or the hypothalamus. So with these patients, they're going to do T3 and T4 and the TSH to determine what the cause is. So again, opposite of hyperthyroidism, everything is down. So they're going to be tired. They're going to have weight gain. They're going to have cold intolerance. My feet are always cold. I have hypothyroidism, and my feet are ice cold, and I'll be wearing a pair of socks and a pair of slippers at home, even in the summertime. I never ever thought I'd wear socks to bed, but now I do. Now I'm a sock wearer. So brain fog, I can always... When I first got diagnosed with hypothyroidism, I felt like I was getting dumb, for lack of a better term. Like, I'm tired all the time. I feel stupid. My brain was so not functional that I didn't realize that I had every classic symptom of hypothyroidism. I had the hair loss, I had the dry skin, the fatigue, the muscle cramps, cold intolerance, weight gain. So just know that, as hyper, everything is up, and hypo, everything is down. Hyperparathyroidism. So that's going to be diagnosed by excluding any other possible causes of hypercalcemia. So these patients are going to have high levels of calcium in their system. So they want to rule out everything else before saying that the patient has hyperparathyroidism. The treatment's going to be focused on decreasing elevated serum calcium levels. You want to have these patients drink, avoid immobilization, thiazide diuretics, and large doses of vitamin A and D. You think it would be common sense, but you tell a patient they have hyperparathyroidism and that they shouldn't take calcium, and yet they're coming in and they're on Tums. So just make sure that they know that antacids usually contain a lot of calcium in them, so they should not be taking those because it's just going to increase the problem. Treatment here is going to be quite similar to what we saw with the hyperthyroidism. So we've got the Tapazole again, and just keep in mind these medications can take some time to work. No thyroid medication really works overnight. It takes a while to get it built up in the system. So these patients shouldn't be taking this if they're pregnant. And then again, thyroidectomy can be a treatment for this. So you're going to assess your airway again, laryngeal nerve damage, that's where they talk with a whisper, and then your Chvostek and your Trousseau sign. We've got a nice little slide here on this. So a friend of mine had hyperparathyroidism and had to have a thyroidectomy as treatment for it, and she is prone to low calcium levels and tetany. The tetany is the worst part of it. So a lot of times she doesn't realize that she's having an issue until the tetany happens. And that's where your Chbostik sign and your Trousseau sign come in. The only thing is sometimes, especially with her, she doesn't realize that she's got a problem until it's not just this that happens to her. Her whole neck turns to the side and it is so contracted that she can't move. Like she can't hardly open her mouth. She'll be like this. So her calcium levels are pretty low when that happens. So just keep in mind that tetany doesn't always look the same, is the whole point behind that. So Chbostik sign is going to be your best indicator. And that starts to happen pretty soon with hypocalcemia, but you do have to tap there to elicit a response on that. Sorry, I'm reading. So one other thing I wanted to say about hyperparathyroidism, I'm going to go back to that for just a minute. So hyperparathyroidism, I wrote this down. So the parathyroid glands are going to be regulating the calcium levels in your blood. In hyperparathyroidism, the serum calcium level is going to be elevated. The parathyroid hormone levels may be high or normal, but they're not ever going to be low. The body will lower the level of vitamin D in an attempt to lower the calcium. So urine calcium may be elevated with calcium spilling over from elevated serum levels, and this may cause renal stones. That was the whole point of me reading this, because it's going to be an issue later on in the review when we're talking about kidney stones. So just keep that in mind. Now we can move on to syndrome of inappropriate antidiuretic hormone. So manifestations and treatment, the signs and symptoms of SIADH is going to occur as a result of water retention, hyponatremia, and serum hypoosmolality. They're usually pretty vague. They may have some confusion, nausea, irritability. And as it advances, they're going to have seizures and coma, and that's as a result of the hyponatremia. I just want you to keep that in mind, because even a few weeks ago, one of my students had a patient that was admitted with hyponatremia, and that was their admitting diagnosis, and their sodium level was like 120. They had an order for seizure pads, and the patient is very upset about it because they said they didn't have seizures. Well, nobody thought to tell her is because she could possibly have seizures, and it turns out she had SIADH. So just keep that in mind. So SIADH results in abnormally high levels of antidiuretic hormone. That's why it's called syndrome of inappropriate antidiuretic hormone. And this causes water retention as serum sodium levels fall, and they gain weight from this. So with fluid retention, urine output is going to be decreased, and fluid intake is normally restricted to prevent fluid overload rather than replacing fluid. So you're not going to let these patients drink as much. As a person's urine becomes more concentrated, the urine the specific gravity is going to increase on that. So the treatment, again, you're going to be restricting that fluid, and they do not like that. They really like to have their fluids. So you're going to go less than a liter a day. You're going to monitor those sodium levels, because really we want to make sure that they're not going to have any effects from that hyponatremia, because they could end up having seizures from that. With severe hyponatremia, they could be having some hypertonic saline solutions. They won't use 0.9, but they might use some half normal with that. I think that's about it for that. So SIADH, syndrome of inappropriate antidiuretic hormone. Diabetes insipidus. Manifestations here, and treatment basically is what we're going to be going over. So they'll have increased thirst, the polyuria, polydipsia, and of course dehydration. So it's really going to be the opposite of SIADH. Treatment for this, we're going to administer hypotonic solution. So you saw in SIADH, we were going with the hypertonic, so it's really going to be the opposite. Encourage PO intakes. We really want these patients to drink. If we restrict their fluids at all, they're going to get dehydrated, and then we're going to replace hormones with them. So we're going to be replacing the antidiuretic hormone because they're losing too much fluid. So comparison side by side, like I said, they're opposite. Syndrome of inappropriate antidiuretic hormone, or SIADH, we have too much. So we have too much ADH. With diabetes insipidus, it's going to be a deficient amount of ADH. SIADH, fluid volume excess, so they're going to have bounding pulses. They could have JVD. We want to restrict their intake. With diabetes insipidus, they have a deficit, so they're dehydrated. They're going to have poor skin turgor. They're going to have weak pulses. We want to encourage fluid intake with them. With, no, I'm not going to go there. Cushing syndrome. So with Cushing syndrome, let's look at my notes again. Cushing syndrome. So we've got too much cortisol from the adrenal gland. This can be caused by pituitary tumors, ACTH producing tumors, adrenal gland tumors, and long-term steroid use. That's usually what's going to be causing it in the patients you're going to see. So you'll see it a lot of times with patients that have COPD. They'll put them on long-term steroids and then they end up getting Cushing syndrome. So too much cortisol from the adrenal gland. The manifestations that you're going to see, they're going to have increased glucose levels, protein breakdown, leading to muscle weakness and poor wound healing. They're going to be a risk for infection, and then they're going to have sodium and water retention, weight gain, emotional changes. And then here is the picture from our previous lecture where we talked about, they kind of look like they're round, they're kind of like an apple on a stick. So they've got that round belly, moon face, buffalo hump, just kind of like a collection of different manifestations. Their skin can get kind of thin and striated. They can have those purple looking stretch marks on them. So just kind of be aware of that. Digestive system. Peptic ulcer disease. So when I'm thinking of peptic ulcer disease with a patient that's getting admitted for something like that, it's got to be pretty severe. So my biggest concern with these is going to be perforation. So perforation of an ulcer, it's going to be a surgical emergency. So that's when they're going to have sudden pain. The pain's going to be beginning in the mid-epigastric area, and that's going to be spreading over the abdomen. It's going to become rigid and board-like. So it kind of like the scenario that we did in SEM 3 with the one patient that needed the NG tube. His stomach was pretty solid, but that was more from a mechanical obstruction. This is going to be really hard and painful. So if you, not that you would knock on it, but I think of it as being like you knock on it and it's pretty hard. So rigid, board-like, painful. These patients can deteriorate quite quickly. So perforation's bad. Think about all the gastric contents in the peritoneal cavity can cause peritonitis. So pretty dangerous situation. Diverticular disease. These are going to be those small little outpouchings, and I have a picture on the next one. They're kind of like a herniation in the intestinal wall, and this is from increased pressure within the bowel lumen, and it kind of herniates through the wall there. So this is what they look like right here. That's the diverticula. So what does this turn into, and how does it do it? So if you think about undigested food, it can really block the diverticulum, so it can get stuck in there. That's going to decrease the blood supply, and that's going to predispose the area to infection, which is where we have the itis, the infectious part of it. So diverticulitis. With this, we're going to be looking at an infectious process. We are going to be worried about their white count, fever, pain, tenderness, and they're probably going to need some antibiotics for this too, to treat that itis. Celiac disease. With these patients, we don't want them to eat bread. They have an intolerance to gluten, and it seems like there's gluten in everything. You really have to be careful with them. So they don't want to eat any types of gluten. That's wheat, barley, rye, oats, and more. There's so much more. So they've got an autoimmune response that happens with celiac disease, and that causes damage to the small intestine so that nutrients aren't absorbed. You really want to be careful with your menu choices. So education with these patients to help promote a healthy diet. I would refer them to a dietitian too, to help them out. Oh, we all know what this is. This is a GI bleed. So your priorities with this are going to be to stabilize your patient and find out where the bleeding is coming from so it can be stopped. So you're going to monitor your patient. Let's see if I've got a list. Oh, I do. Okay, so that's what it looks like. So manifestations are going to be decreased cardiac output, tachycardia, hypotension. So remember, blood pressure goes down, heart rate goes up. They're going to look pale. Remember, with darker skinned people, you need to look at the mucous membranes. You can kind of look at the sclera here, and this can quickly progress to hypovolemic shock. So they could have low urine output, poor vascular return. So look at their cap refill, their pulses are going to be weak. So look at your assessment findings with this. Alterations in consciousness, and even just a slight one like they just feel tired and fatigued, that can be the beginning of a bigger problem. So that warrants in further investigation. This can progress into severe anemia as well. So IV fluid bolus initially to help stabilize the blood pressure. They're probably going to need a transfusion based off the level of bleeding, and then find the source, whether that be an EGD or colonoscopy. So depending on where they think it is. And there's a whole lot of ways that you can determine where that's coming from. Just remember blood transfusion. So effects, nausea and vomiting. If it's an upper GI issue, they can have coffee ground emesis. They can have increased peristalsis, so sometimes they end up having diarrhea. Black tarry stools from this, and if it's quite low, they might also have frank blood. An increased BUN, that's going to be from the breakdown of the RBCs, so that's going to cause the BUN to go up. So treatment's going to be focused on stopping the bleeding and restoring cardiovascular stability. So you want to plug that spot that's bleeding and give them more volume. So IV fluids, normal saline, or a balanced electrolyte solution, depending on what their labs look like. Whole blood, they don't usually do whole blood anymore. They more go towards the packed RBCs or the leuko-reduced RBCs to help restore blood volume. That way they don't put the patient in fluid overload. Endoscopy, they could be using a sclerosing agent to burn that area where it's bleeding. And then, of course, gastric lavage, and lavage means to wash. So they're going to be bathing that area to find out where the bleed is. Paralytic ileus. So think about what a paralytic ileus is, where it is located in the belly. So how are you going to be assessing for this? These patients are going to have abdominal pain. They're going to look pregnant. They're going to have distension. They would have absent or very little bowel sounds, and they could be vomiting. And sometimes that vomiting can progress to where they're vomiting fecal matter, depending on how long it's been. So you're going to ask them when their last bowel movement was, that kind of thing. So you're going to be doing a focused abdominal assessment on them. The treatment for this, they're going to give them hydration with IV fluids. They're also going to make them NPO because they don't want to put more in there, especially if there's a roadblock in there keeping anything from passing through. And then they're going to put an NG tube into low and set that to low intermittent wall suction. I want you to really think about paralytic ileus when it comes to surgeries. Usually that's when I see them happening. Patient undergoes a surgical procedure and they start having diffuse abdominal pain. They can't pass gas. They haven't had a BM, they have no bowel sounds. You really need to just make that patient NPO and prepare to put NG tube in per doctor's order. Can't put one of those in without a doctor's order. Cholecystectomy. So here we have a patient that had a lap chole. Sometimes these patients can get a paralytic ileus. So nursing interventions with this, post-op care, early ambulation, advanced diet is tolerated, and then we provide and reinforce teaching for pain management, activity and incision care, because these patients usually go home pretty quickly. Sometimes they also have a T-tube in, so I don't think I have a slide on a T-tube, but just know that they could have a T-tube in, so we would do T-tube care as well as that, because they will go home with that. GERD, so gastroesophageal reflux disease. We're going to be teaching those patients lifestyle modifications, eat smaller meals, don't lay down after eating, and don't go to bed too soon either. These patients sometimes will be on like a omeprazole, and they do need to take that on an empty stomach before they eat in the morning. Sometimes they'll have it where they take it 2 times per day, but we really want to focus on diet modification, not wearing tight clothing. Sometimes bending over can set that off too. So just education with them. Ulcerative colitis, that's going to be affecting the mucosa of the large bowel, the colon, and the rectum. So really with these, you're going to be assessing for diarrhea and blood in the stools. Because you could have blood in the stools, you want to keep an eye on that CBC. Treatment's going to be anti-inflammatories, TPN, that's the total parenteral nutrition that they're going to get via PICC line, and that's kind of looks like a milkshake, or sometimes it's yellow in appearance, just depending on what type of nutrients are in it. So just keep that in mind. Stay away from foods high in fat because that makes the diarrhea worse. And then Crohn's disease, that's going to be in the small intestine. So it could be diarrhea or constipation. And the big difference is going to be here as far as like what you're going to see with your patients. They're not going to have blood in the stool typically. So UTI, know your symptoms for signs and symptoms for UTI, and then what happens if they go untreated and it goes into the upper respiratory tract. And then the common symptom with elderly clients, of course, is going to be your confusion. Kind of had that slide before this one. Okay. Know how to collect a sterile urine sample. So make sure that you're reviewing the process for that and how you would teach a patient. So you're going to give them their equipment. They're going to have that nice little box. You're going to show them that they need to cleanse the area beforehand. There's 3 little wipes in there. Then they're going to start voiding, and then they're going to catch the rest of the urine. Sometimes it can be trickier, especially if you have a larger patient, but that's what you're going to educate them to do. Treatment for this, they're going to be placed on antibiotics depending on what that culture shows. So initially that could be broad spectrum until the culture comes back. The other thing is they can be placed on pyridium, and this is a urinary analgesic that will help decrease the burning and the urgency. make sure that you're teaching your patients that this can stain clothing. So with the ladies, I tell them to wear a maxi pad because it will stain their underwear. No matter how much you clean the area, it's going to stain. So make sure that you let them know that. Urolithiasis. So we remember we've got some stones here. Maybe they have a problem with their calcium levels. Could be. So we've got some stones. Treatment for this. So they could be doing lithotripsy with these patients. Make sure that no matter what, whether or not they did lithotripsy or if they're just treating it the other way, that you're pushing fluids with these clients. They might have IV fluids. You're straining all urine. So you want to monitor their urine for stones, monitor for blood, and so on. And you don't want them to progress on this. You want to make sure that you're catching all those stones and sending them to the lab for analysis. BPH. The big thing is going to be early onset with this is going to be a change in their urine. So they could have frequency and urgency because the bladder is just not able to drain all the way. So manifestations are going to be basically the increased frequency and urgency. And that kind of progresses with time. Do I have anything else on here? Pyelonephritis. So we want to assess for, this is going to be an upper urinary tract infection. So they're going to have fever, increased white count, flank pain. That's going to be another one. So they're going to have pain in the flank area. And this is going to be treated with antibiotics as well. And they really need to determine the cause of this. So they're going to want to do a urine with a culture on this as well to determine what's happening there. Ileoconduit. So we've got an ostomy here. So you want to do education with your patient. In the immediate post-op period, you're going to be monitoring for bleeding, feces in the bag, because we don't want to have anything other than urine in that bag because it is a urostomy. Decreased urine output, so you're going to monitor their I&O, and then of course you're going to do stoma care on that. Blood loss. We've already talked about blood loss a little bit, but blood loss, acute versus chronic, depending on what's going on with their patient. If it's a GI bleed, they might need to have an infusion. So just be aware of that. How do you treat iron deficiencies? That patient would be on an iron supplementation. So you want to make sure that you're educating them on iron supplements, how to take them, what to take them with. Preferably, we want to take them on an empty stomach, but they do cause gastric upset. And we want to also give them with vitamin C to increase absorption. Folic acid, what you're going to be most concerned about with the risk factors for this deficiency, and of course pernicious anemia and how you would treat that. And I've got more slides on these. So blood loss anemia, we're going to do blood transfusion, of course, IV fluids, stop the cause, whether if it's a GI bleed, so they're going to do an endoscopic procedure. Nutritional support, so we want to include things in their diet that are going to help their body make more red blood cells. So we want to increase iron and vitamins and red meats if they're not a vegan, that kind of thing. And then erythropoietin, which is going to be stimulating the bone marrow to make more red blood cells. Thrombocytopenia. So with this one, we've got a low platelet count. These patients are extremely high risk for spontaneous bleeding and hemorrhaging. So risk for injury is pretty great with these. You want to prevent falls because you don't want your patient to get a head injury. We want to reduce procedures. So if your physician orders IM medication, you would come and say to the physician, hey, please, let's not do that. We've got thrombocytopenia. We could have prolonged bleeding. So make sure that you're advocating for your patient. Your priority here is going to be watch for signs of bleeding in the brain. So we want to make sure that we're keeping an eye on their neurostatus and avoid invasive procedures. So the bleeding for this is going to be related to a platelet deficiency, and this is going to be occurring in the small vessels, like the vessels in the brain. So we could have a couple different things that are causing this: decreased production, increased sequestering in the spleen, or accelerated destruction. A lot of times oncology patients, especially if they're running a fever, because a fever will eat platelets like crazy, they'll end up getting thrombocytopenia, so they'll need quite a few platelet transfusions. This does also, so you know, require a blood consent because it is a blood product. Thrombocytopenia, so you could look for petechiae on your patients. They might have some purpura as well, so you just want to make sure that you're keeping an eye on that. And I know I said reduce risk for bleeding. Just also be aware that like brushing their teeth can cause quite a bit of bleeding too, so use a soft toothbrush with that. No toothpicks. Neutropenia. So we have patients that are neutropenic. We want to avoid fresh fruits and vegetables because they could have microscopic organisms on there. Same thing with pepper. Wash your hands before coming in the room. If you can, possibly, I know this says no Dynamaps, but we do sometimes clean the Dynamap and leave it in the patient's room. It used to be we would have like their own thermometer, their own blood pressure cuff. Well, everybody has their own blood pressure cuff now, but no live plants, no visitors under 12, and the patient needs to be wearing a mask, but everyone's wearing a mask right now, so there's that. So neutropenia, we want to be worried about infection, so we want infection prevention. That's going to be our biggest concern. Monitor their labs, of course. We already know they're neutropenic, so take their temperature often, reduce exposure. Neutropenic precautions, just a little bit more in detail. So we've got a low white count. They usually will do an absolute neutrophil count on these to further investigate that, but usually this is from aplastic anemia or chemotherapy-induced neutropenia. Manifestations, they could have fevers again, weakness, chills. Treatment, so they're going to give them growth factor antibiotics and put them in isolation. And the isolation is going to be protective isolation, so it's to protect them. So you'd come in the room, wash your hands twice, and always wear gloves before touching them, and that is to protect them from you. We're going to jump right into hypertension. I don't know if, going back to here, I don't have a slide on it, but make sure with pernicious anemia, I know I thought I had a slide on it, we've got a lack of intrinsic factor. I just wanted to mention that. I don't see it. Okay, so hypertension. Hypertension, we want to keep an eye on hypertension because it can lead to an increased risk of heart attack, heart disease, stroke, all sorts of problems. So it can lead to peripheral vascular disease, glaucoma. So we want to really prevent that. So your normal blood pressure is going to be like 120/70. So that's going to be our goal for that. Then we have our stages of hypertension here. Again, hypertension, leading cause of stroke for hemorrhagic strokes. It also causes heart problems with the heart, peripheral vascular disease, heart attack, kidney damage, vision loss. Hypertension is just a nasty thing to deal with. So we really want to make sure that we're getting that under control. Primary hypertension manifestations. Sometimes these patients won't even know they have it. It'll be found on a random spot check at the physician's office. Sorry, my phone is ringing. Okay. They could have a headache, especially if it's severe, confusion, nocturia, nausea, vomiting, and visual disturbance. They might have double vision. So treatment's going to be lifestyle modifications. We're going to talk to them about the DASH diet. So they're going to want to go on the DASH diet, reduce their sodium, all the things that they don't want to do, but they really need to do. They could be placed on diuretics. That's going to be like the first line is going to be diuretics. Like they'll start them on hydrochlorothiazide. They could put them on other things too that are listed here. With hypertensive crisis, that's where they're in that severe hypertension. They're going to have that pounding headache and that kind of thing. So your goal for hypertensive crisis is to decrease the blood pressure by no more than 25% in the first hour. And they're going to monitor their blood pressure more frequently. And then you're going to place your patient on a cardiac monitor because we want to know what's going on there. And here's some primary hypertension medications. So diuretics is going to be the first line here. That's going to be your Lasix, your hydrochlorothiazide before they progress them to anything beyond that. The second line is going to be your beta blockers. Sometimes they will jump right from beta blockers down here to ACE inhibitors if they're not controlling that, but they're always going to start with these two up here. One more thing on the DASH diet. So dietary approaches to managing hypertension, they're going to be focused on reducing sodium, maintaining adequate potassium and calcium intake, especially if they're going to be on a diuretic like Lasix that's going, or furosemide, if you prefer the generic name. So anyway, we want to maintain adequate potassium and calcium intake, reduce saturated fat, and patients are encouraged to engage in about 30 to 45 minutes of aerobic exercise most days of the week. They used to say 3 days, but now they're saying most days, just to kind of try to get them out there and help reduce that hypertension. Other lifestyle modifications include weight loss, where you talked about the dietary changes, alcohol use. I don't ever tell my patients to completely eliminate something because they're not going to be able to do that, but you can reduce alcohol. Cigarette smoking, man, cigarettes are so bad. So we need to really educate our patients on not using nicotine products, not just smoking, but using nicotine at all, because it really has quite a bad effect on the body. Increased physical activity and stress reduction. Atherosclerosis and coronary artery disease. So know what it is. We've got a hardening of the arteries. Modifiable risk factors are going to be your smoking, your hypertension, your high-fat diet, infections, inflammation, your weight. So anybody with obesity, oh gosh, those poor diabetics, they're at risk for everything, and inactivity. Non-modifiable risk factors, of course, are your age, your gender, and your genetics. So labs with these, you're going to look at your cholesterol levels, your triglycerides, and your biggest complication of this, of course, is going to be MI and angina. A lot of times with patients that have severe atherosclerosis or coronary artery disease, they're going to put them on aspirin as a preventative. So aspirin, nitro, blood pressure medications, and more, but mostly just going to be the aspirin to start with. What else on here? Peripheral vascular disease. So risk factors, diabetes, again, high cholesterol, hypertension, and smoking. Get them to quit smoking. Manifestations, intermittent claudation. That's when they're walking and they get that calf pain and they stop walking and the pain goes away. So it's intermittent, it comes and goes. Diminished peripheral pulses. You'll have people that have like crappy pulses in their feet. You won't be able to hardly find a pedal, but their radials are fine. Pallor with elevation. So you put their legs up and their legs get pale. Dark red, or rubor is what they call it when dependent. So their legs are hanging down and they're bright red. They'll have shiny, thin, hairless skin and thick toenails because there's no nutrition getting down there to make that hair grow. Edema, skin breakdown. So they're going to give them meds that inhibit platelets, like your aspirin again, Plavix. You want them to have good foot care, stop smoking, control their cholesterol, exercise, everything they don't want to do, and assess them for tissue perfusion. And remember how you're going to do that. So you're going to do your cap refill. What else? Chronic venous insufficiency. Okay. So manifestations, edema, shiny skin, itching, discomfort that increases with prolonged standing, cyanosis, and recurrent stasis ulcers, which are going to be completely different than a pressure ulcer or from a diabetic ulcer. Promote adequate circulation and healing, reduce edema, treat ulcers, elevate the legs, and wear elastic stockings. Angina, that's your chest pain. So your stable angina, that's what it's going to occur with activity or stress. Usually lasts for about 15 minutes. And then after you stop you have your chest pain, you stop what you're doing, the chest pain goes away with either rest or with nitroglycerin. Unstable angina occurs whenever. It has no rhyme or reason, can last longer than 15 minutes, and it doesn't respond well to nitroglycerin. These are the ones that kind of scare me because it's just unpredictable. This happens with low blood pressure or shortness of breath. And then remember what MONA stands for. So we have morphine, oxygen, nitrates, aspirin. And then know how nitroglycerin works. So we're going to take one tablet sublingually. We're not going to chew it. We're not going to swallow it. We're just going to let it dissolve. 5 minutes later, reassess pain, reassess blood pressure. If they still have pain, give them another nitro. You can do that 3 times. With education for patients, I tell them after the 3rd nitro, call 911 if it's not helping. Something else is going on. Okay, we are flying through it. Lungs. So know your respiratory assessments, your lung sounds, normals versus abnormal, normal respiratory rate. PCO2, we want to keep that above 93. 92 is borderline. Cap refill, we're going to assess that, assess skin color, look for cyanosis, look for ease of breathing, retractions, that kind of thing. No oxygen therapy as well. Got lost in the notes. Atelectasis, so this is not a disease but a condition, and it's associated with a lot of different things. It is a partial or total lung collapse and can be acute or chronic. When I think of atelectasis, I think of a post-op complication. Causes: obstruction of the bronchus, pneumothorax, pleural effusion, tumors, loss of pulmonary surfactant, or the inability to open the alveoli. So with these patients, you're going to have diminished breath sounds, tachycardia, tachypnea, dyspnea, cyanosis, and reduced chest expansion. They can also have fever. And I know I mentioned this before, but if you have a patient that's post-op and they develop a low-grade fever and have diminished lung sounds, get them an incentive spirometer. Then you're going to be calling the physician. Hey, patient A had surgery. It's been 2 days. Decreased breath sounds, increased respiratory rate, low-grade fever. Gave him a Tylenol. Gave him an incentive spirometer. Do you want me to do anything else? They're going to think you're so smart that you just took care of that without even calling them. There's certain things that you're allowed to do without a physician order, and incentive spirometer is one of them. COPD, so we have chronic bronchitis versus emphysema. What manifestations are they going to have? So with chronic bronchitis, they could have a productive cough. With emphysema, sometimes it's not so much. Chronic bronchitis, cyanosis, and right-sided heart failure. With emphysema, they're going to have dyspnea and tachypnea and a barrel chest. So that's that big chest. They're going to be tripoded forward, and they're going to be doing pursed lip breathing. So pursed lip breathing. Pursed lip breathing, that's going to be helped to prevent airway collapse. It's a good thing. So we want our patients to have pursed lip breathing. Learning this technique helps the client to control respirations during periods of excitement, activity, exercise, eating. A lot of times they will prioritize breathing over eating so they can be malnourished. Respiratory distress. Pursed lip breathing, the client mimics a normal inspiratory-expiratory ratio of 1 to 2, because the patient with emphysema may have a ratio of 1 to 4, which is going to be a little bit different. And again, a little bit of talking about atelectasis, but we already know what that is because we just talked about it. So decreased breath sounds, they could also be absent, but hopefully we haven't progressed that far. So what education are you going to want to give your patient to prevent atelectasis from occurring? That, for one, early ambulation after surgery and so on. Oxygen use. So long-term is going to be for severe and progressive hypoxemia. This improves activity intolerance, mental functioning, cardiac, helps their heart work better. So this may reduce the rate of hospitalization, increases the length of survival, and reduces exacerbations. COPD patients, just keep in mind they have chronic elevated CO2 levels in the blood. So administering oxygen can really increase their PaCO2 levels, and that can lead to somnolence and respiratory failure. So make sure that you're not just turning that up arbitrarily. Watch your level of consciousness and their ABGs. So COPD, we want to focus on getting them to quit smoking, staying indoors during allergy season, provide cough suppressants and sedatives if pertinent, teach them how to do that pursed lip breathing, increase their fluid intake because it helps immobilize secretions, do the huff coughing, percussion and postural drainage, and treat infections early. So we want to teach them all of that. Pneumonia. So classifications of pneumonia, we've got community-acquired, nosocomial, and opportunistic. So the pathology for this is going to be anything that's entering the lungs. So pathogens enter the lungs, could be flu, words, been talking a long time. Could be food if it's aspiration pneumonia, could be secretions, inhalation of contaminated air, and then through the bloodstream, although that's going to be a little bit more rare. They're spread through droplets and direct contact, and it's usually going to be found in the lower lobes. The most common feature in all types of pneumonia is an inflammatory pulmonary response to an offending organism. So something is causing this to happen. Most have sudden onset, but a few of them are insidious, but they're all going to be caused by an organism. Antibiotics must be given to address that specific organism, so you need to know what it is. Most of the time, these patients are going to have a fever, they're going to have an increased white count, and they're going to need antibiotics. So medications, antibiotics, bronchodilators to treat them if they're short of breath, some anticholinergics, and agents to liquefy mucus. You want to break that up. They might need oxygen, increase their fluid intake to mobilize secretions, and send them spirometer to help with the alveoli expansion, and chest physiotherapy. That's where they do percussion and they shake them up a little bit to help get everything going. PE. So I want you to know what a PE is, what it's caused by, so they can be caused by DVTs. On the same level, know what a DVT looks like, what the assessment findings. So you're going to have a painful calf that's swollen, it could be warm to the touch, and know how to prevent those too. So manifestations with these patients, they are anxious, restless, cyanotic, they have hypertension and tachycardia, and intercostal retractions. Every single time I've had a patient that has had a PE, a big PE, it is fast. So make sure that when you see this happen, you're gonna know when you see it that you're taking care of them quickly because they need the help. Treatments for this are going to be heparin. That's pretty high risk medication, so make sure that you've got protamine on hand to reverse it if you need it. So your priority for fractures, your goal is going to be to stabilize and prevent complications and restore function. We talked about this in lecture, but I'm going to talk about it again. So we want to do our 5 Ps, our neurovascular checks. So pain, pallor, pulses, paralysis, and paresthesias. So anytime you have a fracture, patients in a cast, patients in traction, you're going to be assessing these types of things. You're going to make sure that they don't have increased pain, like their whole foot is pale, they have no pulses, they're not able to feel anything. So sometimes I'll like put my finger on their toe if they're in traction and ask them, what toe am I touching? And see if they can feel that. So complications you're looking for with fractures are compartment syndrome, fat embolism, osteomyelitis, delayed union, or that's when there's like the bones not healing properly. And then, of course, rest, ice, compression, elevation. I think that's everything. There's your Bucks traction. So we have traction applied over the skin. So we want these to be not resting up against the rail right here. They want to be over the bed. I don't think we'll go into detail on that one. Skeletal traction. So the differences is what I want you to focus on. So the difference is Bucks traction is over the skin, and you're going to be testing for your neurovascular checks, your 5 Ps, of course, and then skeletal traction, which is going to go into the bone. And again, 5 Ps. That neurological assessment is going to be the same, no matter what. Neurovascular assessment is going to be the same. There's your 5 Ps again. I cannot stress to you enough with ortho, neurovascular assessment, 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 assessment. Did I mention assessment? Compartment syndrome. So know your signs of compartment syndrome. So let's say that this foot right here had compartment syndrome. So it's going to look dusky. It's going to be cool to the touch. It's not going to have a pulse down there. So you really want to monitor for this, because this is a limb-threatening situation. They're going to need a fasciotomy pretty quickly to reduce this, because this swelling is not going to be able to, it's going to impair circulation there. Your 5 Ps again. Osteoporosis. So these patients have a loss of height, some back pain. It's a progressive curvature of the spine. They're prone to fractures. Treatment for this, you want to give them calcium, calcitonin, prescribe weight-bearing exercises. You don't want to go with aerobic ones where they're jumping all over the place. You want to keep it pretty low-key because we don't want them to get a fracture. Gout. That is a buildup of uric acid. This is going to be affecting the joints mostly. I've seen it affect some really strange joints, but usually it's in the foot from when I see it, but sometimes you'll see it in the hands. It's going to be swollen, red, warm, and painful. Colchicine can be given, but mostly what I see is allopurinol, and then you want to put them on a reduced diet, reduce uric acid levels in their diet. Bed rest and elevation of the extremity for this one. Osteoarthritis. So we've got this affecting the joints. Most of the time it's going to be the larger joints. So you'll see it in the knees and the hips. I really want you to know your hip precautions. So with your hip precautions, do I have a separate? No, I don't. Okay, so hip precautions, we don't want any bending past 90 degrees. We're trying to prevent dislocation of that limb. You want to use this pillow. You want to reposition them appropriately. Use an elevated toilet seat to keep them from bending past 90 degrees and that kind of thing. The other thing with this is the risk factors associated with any type of joint surgery are DVTs. That being said, we want to prevent these. So surgery is going to be the biggest one. Immobilization is going to be the other one. And you see that this leg is immobilized. These patients are going to be walking with a walker when they're up, but they really need to be educated on prevention of DVTs. So you want to use your SCDs on them. You want to be giving them their Lovenox is usually what's scheduled for them. Sometimes they're on Coumadin, but more often they're going to be on Lovenox because it works faster. So you want to teach them how to use that because they might go home with that. With teaching for Lovenox, You want to make sure that you're telling your patients how to give it. You're going to give it in the love handles, and you really want to tell them that it could increase bleeding. So they need to be careful and watch for bleeding. Use a soft toothbrush. Osteoarthritis. So this is going to be a breakdown of the weight-bearing joints. Mostly with this, with as far as the most common pain medication they're going to be given for this is going to be your Tylenol. You want some exercise, but not to the point where they're going to have pain. Of course, doing exercise in a pool is going to be the best thing for them. Treatment for this is also going to be focused on losing weight and potentially having a joint replacement. Rheumatoid arthritis, however, is going to be a chronic immune disorder that produces antibodies that destroys all the joints. So in osteoarthritis, you got one of the weight-bearing joints. It could be one, could be two. With rheumatoid, it could be all of them. It does cause deformities, and you want to talk to them about exercise because that's going to help relieve pain. So they'll wake up in pain, and then once they get moving, that can kind of help. They want to ice their joints down before exercise. Again, pain is worse at rest. And then they're going to be taking NSAIDs and corticosteroids. Whew. That's how my brain feels right now. Yours is probably more full, right? So, neuro. I'm not going to hit this one really hard. You notice I kind of hit the earlier sections harder since it's been a while since you probably looked at those. But we're going to talk about stroke just real briefly because there's also another PowerPoint up there about stroke and you just learned about it. So biggest risk factor, we've said it a couple times, hypertension, age, lifestyle, manifestations. So fast, face, arms, speech, and time. So weakness that involves the face and sometimes the leg, sometimes the leg, meaning you could have just the face and the arm but not the leg, but one side's going to be weaker. One-sided numbness, loss of vision, speech difficulties if they've got a problem with aphasia, sudden severe headache if it's a head bleed, loss of consciousness. So your priority treatment is going to be your ABCs, so airway, breathing, circulation. Check their blood sugar first because we know that hypoglycemia can mimic the signs of a stroke, and then get them into CT right away. So we want to make sure that we rule out a hemorrhagic stroke in that CT, because if we know what time the stroke started and the CT is negative for a bleed, they could have some TPA to treat that. So we want to make sure that we do that. If it's a hemorrhagic stroke, we need to stop that bleeding. So think fast. So TPA, again, who qualifies? We're not going to give a thrombolytic to somebody who's had recent surgery, who's already on blood thinners, or who has a head bleed. So they have to have an embolic stroke to qualify for that. Parkinson's disease. 3 classic signs of Parkinson's. We've got the tremors, we've got muscle rigidity, and bradykinesia. Muscle rigidity and the tremors are going to be what you're going to see the most. So impaired mobility, same thing with the stroke. I think we talked about that in the review, that you want to make sure that you're repositioning because those patients can't reposition themselves. Risk for aspiration and disturbed sleep. Glaucoma. So manifestations, painless. It's a gradual narrowing of the visual field, and if you don't treat it, it's going to lead to blindness. Treatment's going to be early screening and eye drops, and those eye drops they're going to be taking for the rest of their life. The other side of it is retinal detachment. They're going to have floaters in the vision, lenses or flashes of light. They're going to have a curtain sensation where it's kind of, the vision's just kind of like a curtain. Scleral buckling, and you're going to teach the patient to avoid head movement to prevent detachment again. A lot of times when I see these are your diabetic patients that happens in. Okay, that's a long lecture. So I'm not going to make it any longer, because some of these other smaller disorders, there might be like a question about it. So Bell's palsy, Look at that face right here. So it's one side of the face that's droopy. We've got paralysis in that facial nerve. Meniere's disease. Wait, that's not Meniere's disease. This one is. So that affects the ear. So I want you to think about what symptoms, manifestations you would see in a patient with Meniere's disease. Are they going to have tinnitus? Yes, they are. So make sure that you know that. Know what proboscis is. And then, of course, this is cataracts. So there might be some information about that on there. I'm not going to make this any longer than it has to be because it's a pretty long video. I will get it posted to you ASAP. And I hope this helps you. Have a great day.